26 of the Andean Health Organization, Orasconu. It's been 4 years of learning, continuous learning, since we started this cycle of webinars in May 2020. Likewise, since February 2024, we started, along with the British Embassy in Peru, a cycle of hybrid webinars with experts who shared the British mission on different priority topics. Today, Thursday, June 6th of 2024, we are going to talk about the British mission and its view on cancer in adults and children, with an approach on the challenges and accomplishments for the prevention of cancer considered as a priority for public health. Cancer is one of the main challenges in the countries of the Andean region. It is a top death cause by a non-communicable disease between 5 and 18 years of age. And we have a high prevalence in Andean women of breast cancer, cervix cancer, and colorectal cancer. And in men, the prostate cancer, stomach, and lung cancer prevail. We require then a holistic approach of these problem and prevention, education, access to the different services, regional cooperation, funding, and social participation. Some reflections about this and other relevant issues for the well-being, you can find them on the NotiSalud Andina newsletter, monthly edition, available at the Orascon website, and also on the knowledge mural of Andean integration. Next, we would like to invite you to drop your name, the organization you come from, and the country you are from in the chat box on Facebook and YouTube Live. In this very same space, you can drop your questions or send them over the email webinarorasconu@gmail.com. In order to have access to your attendance certificate of this webinar, as usual, you need to fill out a brief survey and drop your information with your email. This is the link for the form is located in the chat box of Facebook and YouTube Live. Please make sure your email address is correctly written so you can get your certificate. This webinar will follow the following dynamics. We will first have the institutional greeting, followed by the keynote speeches, and then we will start dialogue based on the comments of our guests, and also questions dropped in the chat box by the online attendees. In order to kick off this important webinar, we are going to give the floor to the Excellence Ambassador of the United Kingdom in Peru, Mr. Gavin Cook, who will give the welcome and the institutional greeting. Ambassador, you have the floor. Thank you very much. Thank you to everybody for being here in person and also online. For me, it is also very important to be here. First of all, I would like to thank Dr. Maria Carmen Calle, Executive Secretary of the Andean Health Organization, Orasconu, Dr. Carrospi, Director of the National Cancer Institute in Peru, also Dr. Maradiego, Executive Director of the National Directorate for Prevention of Cancer, Dr. Thomas, General Director of the Children's Hospital, dear authorities and representatives. I am very happy to be able to join you today in this fourth session of our cycle of webinars along with the Andean Health Organization. I would like to thank you for your time. I know that you have a very busy agendas, and so I know that this session is going to be very, very interesting and very useful for you. I just also wanted to thank the Orasconu team, with whom we have been able to work together in the organization of these sessions. It's definitely been a success. And this is something that motivates us to join our efforts, because we know that this has been very productive for the ministries of health, both from Peru Bolivia, Chile, Colombia, Ecuador, and Venezuela. But also, and online that we are reaching them out. Definitely, health is one of our priorities as a government, especially in topics that are so complex like cancer. And that's why we trust in the experience of our national service, British National Health Service, NHS, whose representatives are joining us, and they will join us with their presentations. With this, speakers, they have an experience of over 30 years in this sector, and they know firsthand about a series of processes, and they can provide different recommendations that the teams in this region can then implement. Fortunately, I I am not one of the speakers, but I also have experience firsthand of the NHS service. And, I had the privilege and honor of going to different appointments. And then also, on the other hand, something that was scary for me, which is to go to a breast cancer clinic to check if I have an issue. And well, fortunately, after some tests, I didn't have it. But it was also very interesting to see firsthand how the services work and to experience the service and the expertise of our experts, the doctors that work in the service. And really, it gave me an experience that has really fostered my commitment. I also come from a medical family. My father was a doctor, my mother was a dentist, my brother is a surgeon, my sister is a general practitioner and also a cancer expert. So I am the black sheep in the family, really, because I am not a doctor. I'm not in the medical field at all. But definitely, uh, I know that they have a lot of experience. Definitely, it's like I said, it's my family and it's a personal commitment. Definitely, the speakers will talk about different topics in terms of practices and prevention. We have experience examples of public policies and also the use of technology that are already working in the United Kingdom. And we really hope that this session is useful, productive, and you can then share these ideas with your respective teams. At the embassy, on my part and on my behalf, I would like to reassert our commitment towards health in Peru and the region. And definitely, there is an impact that we can make together in the lives of millions of people. And that is something that we are developing a lot. We're working at the embassy, and I would like to thank Andrea and Regal for all of their efforts, because really, I think that in the past 2, 3 years, we have changed a lot of lives and we have changed our approach. And we know that we are somehow supporting, these links with universities, with the academia, and research academies and Cayetano. We have been working with Cayetano Heredia Hospital and University. We're definitely trying to increase our knowledge, and so definitely this is one of our objectives as an embassy. So thank you very much for your time and attention. Thank you. Thank you, Mr. Ambassador. Thank you for welcoming us here at home, our institutional home. We would like to invite now Dr. Maria del Carmen Calle Davila, Executive Secretary of the Andean Health Organization, Horas CONU, who will give her welcoming words and institutional greeting. Thank you, Your Excellence, Ambassador Gavin Cook, Dr. Reina Bustamante, Dr. Madariaga, Dr. Garrospi, Dr. Payet, Dr. Venegas, and doctors here on representation of Dr. Thomas and everybody who is here, all of the members of the team at the embassy, at the British Embassy. In this month, we have been collaborating very closely, and really, we are very, very pleased and happy with this joint work. Also, we would like to greet the whole team at the Orasconu and everybody who's attending today, especially the speakers, our guest speakers who will join us today and will share their knowledge. Thank you. And then also thank you to all of the attendees that week after week are following us, are joining these webinars. And I think that this, hybrid seminars, I think we have provided an important advantage to these meetings, and we really want to thank that. Since February 2024, we started a cycle of conferences in collaboration with the British Embassy in Peru. Our objective is to contribute to knowledge of strategies and solutions that are innovative in the public health field. Through these events, we tackle and deal with key issues. We have talked about strengthening of health systems, digital health, mental health, and most recently, like today, we're talking about cancer. These conferences allow us to get these knowledge and experiences of the experts of the United Kingdom closer to our colleagues here in the practice and also public health officers in the Andean region. Also, our public, the ones who follow our webinars, are also benefiting from this exchange of information. We are fully committed to providing an important contribution to education, awareness, and international cooperation. Because in the end, what are we? We are an regional integration organization. That's why we do that. So cancer is an important public health issue. In the year 2020, almost 10 million deaths were reported regarding to and related to cancer. This accounts for approximately 1 out of each 6 deaths registered in the world. The most frequent types of cancer in newer cases include breast cancer, lung, colorectal, prostate, skin, and stomach. Also, every year, 400,000 boys, girls, and adolescents are diagnosed with some type of cancer. I really cannot deny that, I am a pediatrician. So for me, pediatric cancer, something that is very dear to my heart. The Center for International Research on Cancer has detected great inequalities in the more developed countries and the developing countries. For instance, in countries with a high Human Development Index, 1 out of every 12 women will be diagnosed with breast cancer, while 1 out of 71 will die because of this cause. In comparison, in countries with a low Human Development Index, 1 out of 27 women is diagnosed with breast cancer, but only 1 out of 48 women will die out of these because of a late diagnosis and lack of access to a quality treatment. The inequalities and disparities are the reason of why we're here, why we do what we do. And our vision for 2030, it is clear. We want to reduce inequalities and disparities. And that's why we have an intersectorial roundtable in the Andean region that deals with this topic. Altogether, the estimated number of new cancer cases in the countries with a low Human Development Index will increase by 107% between 2022 and 2045, while the estimated number of cancer cases in the countries with high Human Development Index will increase by 36%. A survey that was performed by the WHO in 115 countries showed that most of the countries do not adequately fund their oncological services as part of the health insurance coverage. That's why the experts are requesting for a greater investment to deal with the differences between and among countries. Peru has a motto that we always use: without budget, there's no rights. And really, without a budget, we cannot really reach to everybody who needs it, and there's no rights. The CIC has stated that the estimations need to be interpreted cautiously and with a grain of salt due to the limitations in data about cancer in the world, especially in the low and medium income countries. In the Andean subregion that is made up by Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela, in 2022, a total of 346,457 new cases were reported, with an adjusted by age incidence rate of 169.3 per 100,000 inhabitants, and a total of 186,635 deaths, with an adjusted mortality rate of 83.6 per 100,000 inhabitants. All of the cancers that affect the Andean women the most are breast cancer, 43.7 per 100,000, cervix cancer, 18.8, colorectal cancer, 14.4, thyroid cancer, 9.2, and gastric cancer, 8.7. In the case of the Andean men, it's prostate cancer with an incidence rate adjusted by age of 48.5 per 100,000, colorectal cancer, 16.6, gastric cancer, 16.5, and lung cancer, 13. We have, since 2022, the cancer prevention and control Andean policy that was approved by the different ministers of health of the 6 countries. And this is the job of the Orasconu. We generate policies, programs, and projects that will actually be applied in all 6 Andean countries. We also conducted an Andean situational diagnosis of cancer, and we also have the Andean situational diagnosis for pediatric cancer. We also have a roadmap to improve the care for boys, girls, and adolescents that encompasses the period 2024 and 2030. And also, there is now a publication of the best practices for South-South cooperation. Early diagnosis of pediatric cancer. This was done jointly with the Andean Cancer Committee. And I want to say clearly that the Andean committees are made up by official representatives from each country. And most of the times, it is the directors of the different cancer hospitals or cancer centers. They are part of this committee. So we work this with the PAHO and St. Jude Research Hospital, with whom we're also working together. And I remember that the first time that we talked with St. Jude Hospital was a long time ago in 2016, when I was general director. And, processes, right? Dr. Payet, sometimes the processes are lengthier than we would like. But in the end, slowly but steadily, we get to where we want to go. And then, so we now are going to sign an agreement with St. Jude, probably the next, or maybe in the next couple weeks. We are going to have this partnership to harmonize the policies, strategies, and plans to fight against cancer in the Andean region. We know that we cannot do this by ourselves, and we need to work together. We would like to thank to His Excellency Ambassador of the United Kingdom, Gavin Cook, to the different embassy officers for allowing us to have these work together with our experts and authorities of the Andean countries. Highly distinguished professionals like Dr. Majid Kasmi, Director of Innovation for Cancer and Surgery at Guy's and St. Thomas NHS Trust, and also Dr. Richard Lee, consultant physician in respiratory medicine at the Royal Marsden Hospital, and Dr. David Fitzgerald, Director of Policy and Strategy for the Cancer Hospital at the NHS in England. Also, we would like to thank our special guests, like Dr. Francisco Berrospia Espinosa, head of the National Institute of Cancer Diseases in Peru, Dr. Elsie Milagros Maradiaga Chirinos, Executive Director of the Directorate for Prevention and Control of Cancer of Peru of the Ministry of Health, and Dr. Eduardo Payet Mesa, past president of the National Cancer Institute in Peru. They will provide their comments based on the keynote speeches. So thank you very much and welcome everybody.
I should say, embarrassingly, I've been a patient at both the Royal Marsden and at Thomas's, and I can vouch, they're fantastic. So there we go.
Muchas gracias, estimado.
Thank you very much, Dr. Calle, for your welcoming words. And now I'm going to introduce myself after the institutional greeting. My name is Luis Bengolea More, coordinator of the Andean Committee for Prevention and Control of Cancer at Horas CONU. And I am going to be moderating this webinar. The first presentation to start the keynote speeches is dealing with transformation of the cancer services by Dr. Majid Kasmi. So we have Dr. Kasmi's bio, and so we find that he is a clinical director of cancer services for Guy's and St. Thomas NHS Trust, the Hospital of the National Health Service in the United Kingdom. He is a graduated at the Aberdeen University in 1991. He is a member of the European Group for Blood and Bone Marrow Transplant, also a member of the International Myeloma Society, the Leadership and Medical Management Faculty, and also the American Society of Hematology, ASH. He's been a consultant since 2001 at Guy's and St. Thomas NHS Trust. Is the Director of Innovation for Cancer and Surgery at the same hospital. Specialist advisor for the Care Quality Commission, who has supported the work of the National Institute for Health and Care Excellence, NICE, providing expert advisory to support the technology assessments in myeloma. He's been the head of cancer services and clinical director of oncology and hematology. Welcome, Dr. Majid Kasmi. Please, the floor is yours.
Hello, buenos dias, everyone, and thank you so much for giving me the opportunity to present to you today. And I'll start off, hopefully, get my slideshow to work now. Sorry, my slides are not advancing. Can you see this? Okay. Hopefully you can see my slides moving now.
Not yet.
No, we can't see them.
Which slide can you see on the screen?
Your view at the moment, seeing a video of you still, I think. Maybe not.
Aún no lo vemos, doctor.
We can't see anything yet. We can't see a presentation. Any slide, we just see you.
Oh, sorry, just share that again.
Okay. Yes, now we do.
You got it? Oh, okay. So apologies for that.
Your second slide, just
So are you on the slide with the cartoon?
Yeah.
Okay. So thank you.
Perfecto.
This slide is a cartoon we drafted as Guy's and St. Thomas's probably about 8-9 years ago. And the relevance of it is that you have the patient at the center here, and what you're looking at is an ecosystem of support for a patient with a cancer diagnosis. And that ecosystem is increasing all the time. And it's a multi-agency approach that is required to manage cancer patients now in the 21st century. And as cancer changes from what has been traditionally a very acute illness into much more of a chronic illness as we get better success with our treatments, that multi-agency approach becomes ever more important. So just trying to advance my slides again. So it seems to keep getting stuck. Right. This is the challenges with technology. Right, can you see the next slide? So hopefully you can see the slide of the aging population. And I think this is what the introductions were highlighting, which is the real demographic challenge we face in cancer medicine is that cancer is primarily a disease of the elderly. And although we do see it in younger people, it is much more common as you get older. And the population across the globe is aging. And in particular, it's aging much more rapidly in the developing countries. And so the incidence that was quoted earlier is a reflection of that real demographic challenge. And you can see this graph shows the how long it took for the population in France, for example, that was aged over 65 to double, and it took over 100 years, whereas in Brazil, it's anticipated that that time frame will happen within 20 years. So there's clearly a cancer challenge, and this is a global challenge. You know, we have challenges in the UK, there's challenges in the US, and there's challenges in many other systems across the world. And it's about an increasing burden. It's about the demographic changes I've discussed. It's about better diagnostics and diagnosing more and more patients. It's about a workforce that needs to match the increasing demand and the challenges and the time to train and recruit doctors, nurses, other health professionals creates a pressure on every system. And, you know, technology moves on at a pace that's unprecedented in human history. We're working in an era where technology really is driving many new insights and many new ways of treating and managing cancer diagnosis. So what I'm going to focus on in this talk, and I'm happy to talk about other things, but I'm really going to focus on how we, Guy's and St. Thomas's, have really tried to adopt certain aspects of technology to really help us deal with some of the challenges we have within the increasingly busy NHS. And when I look at technology, I always look at three guiding principles. It needs to improve patient experience and outcomes by allowing us to be more precise in what we do as healthcare professionals, and also releasing time to care and focus on the tasks that we need to focus on. And thereby should improve staff experience and their ability to support patients through their treatments. And the byproduct of that should be an enhanced efficiency for the system as a whole. And if you can meet all of those three objectives, and this is a technology that we should be looking to adopt within our practice. Now, the challenges to deployment of technology, and AI is a very good example of this in the NHS, is multiple. And this is a global challenge. It's not just related to what we do in all healthcare systems. You'll find the same things, which is how do you integrate any new technology with existing systems? How do you integrate it into clinical workflows? Because it has to fit in with the clinical workflows in a way that makes sense and is coherent. How do you prepare your staff and train them and educate them to exploit new technology, and in particular things like AI? And ultimately, how do you assess the value of the new intervention? Does it actually make a difference to patient outcomes? And a real important challenge in most healthcare systems is sustainability. Quite often, and I'll talk about this a little bit more, we start off doing pilots and initial initiatives, but really to scale and deploy and make it sustainable is a real challenge. So we've been working very early on. We set up workshops internally, and then we worked with the BSI, the British Standards Institute, to really look at what validation frameworks you might want to think about developing when you're assessing artificial intelligence and its role in healthcare. And this ultimately led into this BSI specification. And it was my team at Guy's and St. Thomas who were really quite instrumental in helping the thinking along the route for adoption of AI in healthcare. We're very fortunate at Guy's and St. Thomas's and with the University of King's College London that we have a very big health technology assessment center. And as you can see on this slide, to assess health technology properly, you need multiple specialists, not just doctors and nurses. You need health economics, You need research scientists, computer scientists, data analysts, data scientists, implementation scientists, statisticians. That team is very big. And we certainly are well placed at Guy's and St Thomas. And one of the things we could discuss working with centers across South America is how we can help evaluate technology and make sure that what it says on the tin is really what it does for you in your health system. I'm going to give you a few examples of some of the work we've done just to highlight some of the initiatives and where there may be a potential usage in other health systems. So Careology is a company, a startup company that I worked with. We initially started a conversation with them about 2.5 years ago. And what it is basically a patient-held app. So really what it's doing is trying to empower patients to understand cancer diagnosis, record their symptoms, give them reminders around their medication, and allow them to interact with healthcare professionals in a much better way. And it also allows them to select amongst their families and friends and carers who they would want to share bits of information with so that they can also have a view of what's happening with the patient. And really what it's doing is it's taking care outside of the hospital boundary. So the aim of this treatment is allow me as a clinician to have line of sight of my patient when they're not in front of me in the clinic, but also allows the patient to have much more robust and meaningful interaction with the healthcare teams. And what it's really allowing is information to flow around the system rather than the patient historically having to go around to multiple points of the organization, the healthcare system, and having to repeat the same information on multiple occasions. And so what you see here is just a screenshot of what it looks like from a patient end and what they can see when they log onto it on their phone. And then what I see as a clinician on the computer screen is a dashboard which tells me immediately whether a patient has recorded any symptoms of concern, anything that's worrying them. 24/7 they can record that and I can look at that, and they will flag up whether I need to contact that patient directly because there's a real concern, or whether I need to signpost them maybe to the pharmacy, maybe to a psychologist, maybe some other support because they're struggling. And we have now been running a pilot at Guy's and St Thomas's over the last 2 years, and it's working really well. Patient satisfaction is very high, and we're now looking to roll this out more widely, both across our hospital, but also across healthcare systems in the UK and beyond. Another area that we've looked at is the recognition that in cancer diagnosis, we often develop the management plans with big multidisciplinary team meetings where we convene the relevant specialists, whether they're radiologists, whether they're pathologists, whether they're oncologists, surgeons. We all get together on a weekly basis or twice weekly and sit together and go through every patient newly diagnosed and decide on what's the best treatment for that patient. That is a really labor intensive, expensive meeting. It costs our organization of Guy's and St Thomas's about £3 million a year to run that meeting with all the specialists. And that's time that could be spent for them actually seeing and treating patients. So we launched many years ago an initiative to try and look at how we could streamline our MDTs and use technology where it's appropriate to try and make some of that decisions for us. And initially we worked with IBM with their Watson for Oncology technology, which is no longer being used. And we piloted it in breast cancer. And what we really did was we looked at, in a retrospective and a prospective manner, at patients who'd been through an MDT and what the decision was. And when we put the same data into Watson to see whether it would come up with the same answer, and then we did it prospectively. And what we found with this initial work was that about 40% of patients, we could identify that Watson for Oncology gave the same answer as our specialists with 100% concordance. And as a result, potentially 40% of patients who are going through the breast cancer pathway didn't need to go through the MDT. They could just straight go through the Watson for Oncology tool and give you an answer within seconds. Now, Watson for Oncology, and this is we published this data a couple of years ago. Watson for Oncology, like I said, was a really ambitious project and was trying to probably a bit like a sledgehammer trying to crack a nut. It was probably a bit more ambitious than it needed to be. And once that pilot finished, we worked with another company, which is a spin-out company from Oxford University. And they had a much more simpler AI tool for decision making, and it's called Deontics. And we initially piloted it in prostate cancer, so that's why it's called Prosaic DS. It's a prostate cancer decision support tool. And what we did was an NIHR funded study for 2 years looking at prostate cancer, again, retrospectively, and then in real time, and then prospectively, to see whether we could identify patients in the prostate pathway who didn't need to go through full MDT. And this is just shows you some of the information you input into the Deontics tool. This is some of the imaging and pathology data that you put in, and then basically you put all of this information in, and it gives you evidence-based suggestions, and it grades the recommendations based on what the strongest evidence is, and it can give you all of that evidence for you within seconds. And again, similarly, what we did, it can also signpost you to clinical trials which might be appropriate for that patient. So the real potential of this tool, and we've now been able to show in prostate cancer, again, about 40% of prostate cancer patients do not need to go through an MDT. They can just go through this tool, and again, it comes with exactly the same answer as our experts would come up with. And what it has a potential to do is to streamline your MDT, free up clinician time to discuss the more complex cases or to do clinical work. But also what it does, it levels up decision making across systems. Now, the NHS, we're very fortunate, and most of our hospitals have lots of experts. But we know even in the NHS, there's variability in decision making depending on which experts are in the room in the MDT at the time you have it. And this really is a really great way of leveling up the decision making and reducing unwarranted variation. And we're now rolling this out in breast cancer. And in fact, the preliminary results we got in breast cancer are even more exciting. We think maybe up to 70% of patients can go straight through this pathway without having to go through an MDT. And we are planning to roll this out in the next few months over the Cancer Alliance in Southeast London and hopefully wider. So changing tack a little bit, one of the challenges we know we face is around surgical training. How do we get our surgeons skilled as quickly as we can, and how technology can help? And one of the companies is spin out from Guy's and St Thomas's is Proximie, which is a software platform which really gives you a direct view into the operating theatre. And what it can be used for is training. It can be used for complex surgery where you may have specialists from across the globe helping assist the operator within the theatre in real time to do the surgery that needs to be done for these cases. And so hopefully making surgery both safer and more efficient in healthcare systems. Building on that, we're working with another company called Innosight, which is creating 3D interactive models, which allows us to define organs that may be at risk during a surgical procedure and the margins that we need to obtain. So what we basically do is we load the imaging images up into the software platform, and it gives us a 3D reconstruction of those images to tell the surgeon where they need to be operating and how close they can get to organs that are vulnerable. And again, we piloted it in thoracic and urological surgery, and it's really helping our surgeons do operations previously they would not have been able to undertake, and making surgery much, much safer. One of the other things I'm very keen on is about how we improve the quality of our data. And so we're working in cancer at Guy's and St Thomas is working in partnership with Barts and Queen Mary University London to really harmonize our data, so to create what we call high dimensional multimodal data sets, which can then be used to create new insights into cancer discovery, but also help improve the way we do things, our own process, and train new AI algorithms. Now, what we're doing is leveraging 50-year-old biobanks that we have both at Guy's and at Barts that we've established 50 years ago with huge amount of clinical and pathological data in there. And we're using that as our basic platform to create this really exciting multimodal data set. And obviously the real value of this is as we can get more centers to join in this initiative, we can really start to drive through what we call precision oncology and really tailor our treatments much more precisely to the patients that need them. Other things that we're working on is clinical trials matching. I think this is really important, particularly for systems where access to therapies may be limited and the only way you can access them may be on clinical trials. It's really important to try and find trials for patients. It historically has been a very manual process, very labor intensive. So we worked with a company, a US-based company called Inspirata, looking at early phase trials where you really need to match clinical data with genomic data and really identify the mutations that are suitable for these early phase studies. And that would take, on average, one clinical trials person maybe 4 or 5 hours to pull all of that information together. And working with this company and using natural process languaging and extracting information from the EMR, we were able to bring that down to minutes and identify trials for patients. So again, really exciting technology. But the main use case, I think, particularly in developing countries, is where those trials are available, it gives patients access to drugs that would not be routinely commissioned. AI is really forging ahead in imaging, and we've been working with a few companies in imaging, looking at things like lung nodules, identifying areas of concern. And again, with a shortage of radiologists and the training required for radiologists, using AI as your first read, or at least identifying those areas where the radiologist needs to look, shortens that reporting time. And we've had really good success both in terms of lung nodules, but also looking at blood clots in the lungs. We found that AI technology is actually a lot better than many of our radiologists at identifying things that we were missing before. Similar in digital pathology, we're working with a company called Page AI, which is a company that spun out of MSK in the US. And we were working with them looking at axillary lymph node clearance in patients with breast cancer. And as you know, when patients have breast cancer treatment and we look at the lymph nodes, we're looking to see whether there's any evidence of involvement. There may be up to 20 lymph nodes you need to go through, and that can take a lot of time for a pathologist. But using technology and digitizing this process with AI, we can scan through multiple slides really very quickly. Again in minutes, and this again is a tool we validated at Guy's and St Thomas's and is now FDA approved. Radiotherapy is a real challenge, particularly around the computing power and the medical physics requirements for radiotherapy. And we've been working with companies in the AI space, and we've now developed our own in-house solution around auto contouring, which basically means mapping the area of where you want to deliver the radiotherapy to safely and avoiding organs at risk. And this is a very complex bit and very manual bit that's currently done by experts who have to go around and drawing with a pen around the tumor and identifying what doses will go where. This can all be automated and done now using AI, and again shortening that. And the real advantage is that we can do the planning centrally in one location, and we can then send the plan to a delivery LINAC, wherever that may be, and that just loads the plan and you can deliver that treatment. So that allows you to consolidate your medical physics and your computing power and expertise in one center, and then allow the treatment to be delivered much closer to the patient. Other areas, just to mention, that we're very actively involved in the research side is around patient-derived organoids. So this is just a 3D tumor model where we grow up from patient tumor cells, we grow up with 3D models. And what that really allows us to do is to test with those patients drug therapies and identify new therapies that might be appropriate for those patients. And we've got real good success now in bowel cancer, in esophageal cancer, and head and neck tumors, or developing these organoids. And again, it allows researchers to really test new treatment options in a way that up to now has been very difficult. And then coming to the end of my talk, education is really important. We set up about 5 years ago the Guy's Cancer Academy, which was really set up as a finishing school to really upskill our own internal teams around cancer medicine. But it's been so successful. We developed a really strong online presence. We've got a really strong e-learning platform, and we are now training people across the UK, but also globally. We've got a big work program in India, helping train up the cancer grid there with education and training, and certainly something we'd be very keen to explore with South America, which is how we can help support that education piece, which really is important going forwards, given how quickly cancer medicine is advancing. So I'll finish there. That's really been a whistle-stop tour in 15 minutes, but I'll stop, and I'm happy to kind of take questions. Thank you very much for your attention.
Excelente, doctor Majid Kazmi. Ha sido una muy
Excellent, Dr. Kasmi. It has been a very fruitful presentation. I can summarize this, that in your institution, you have been strongly working to articulate the efforts of different areas with technology, with artificial intelligence. And this has allowed you, in short, to just give more access to advice for patients to require this without the need to be having a direct presence with specialists. 40% is a very important figure as a response to patients who consult about their cancer. On the other hand, you have also underscored the need to bring together technology with the prevention and attention and the control and care of the patient with cancer. Thank you very much, Dr. Kasmi. We invite you so that you might stay on the hall, and in the end, perhaps we can do all the questions that might be presented by our guests. We would now to talk about artificial intelligence for the early detection of cancer and the program of the UK for the lung cancer detection. We would like to greet Dr. Richard Lee. In his bio, we see that he's a doctor, consultant in respiratory medicine, and advocator of the early diagnosis of cancer at the Royal Marsden Hospital. He has clinical interest in respiratory medicine and early diagnosis of lung cancer. He has a doctorate in lung cancer done from the King's College London, and the study of resistance of the lung carcinoma, and he leads the development for innovating studies with ICR, and he also works in this area, and his study is also funded by the Royal Marsden Cancer Charity. And he just links AI with early detection of cancer. He also leads the strategy of early diagnosis at the Royal Marsden, that is developing innovating clinical services to guarantee that the Royal Marsden become an international intellectual leader in early diagnosis, and to contribute actively towards the objective of the National Health Service England for 2028 of diagnosing 75% of all cancers in an early phase. He is the co-director of the Center of Detection and Early Diagnosis at the Royal Marsden. And again, as I said before, his work in this area is funded by the Royal Marsden Cancer Charity, with whom he continues working closely to promote the importance of an early diagnosis of cancer amongst patients, colleagues, and the public in general. Welcome, Dr. Richard Lee. You are acknowledged.
Gracias. Muy buenos días a todos.
Thank you very much.
So here are my disclosures. So the Royal Marsden is a cancer-focused hospital in London. We are going to talk a little bit about an area of interest, thinking about early detection of cancer and why that's important, to try and give some context of how AI might apply. So there's obviously a lot of interest and a lot of hype in this area. And so I sort of trying to focus on how that's evolving, but first to give some context. So there's a very big target in the UK trying to understand how we can make the diagnosis of all cancers happen at an earlier stage. We can see in this graph that along the bottom of the graph is the current amount of patients in a percentage that are diagnosed at an early stage and the total burden of that cancer. So we can see lung cancer is both a very common cancer, but also one in which most of the patients are diagnosed at late stage, so very low rates of early diagnosis. And we can sort of see that in comparison to other cancers. That helps us to sort of think about the big picture and how we might focus our different initiatives of research, but also sort of helps to understand the scale of the problem that we face in lung cancer. Why is early diagnosis important? So we can imagine that in those kind of tumours that are very small, as at the top of the screen here in this scan, are much easier to treat than those are more advanced and more complicated. And these graphs simply represent the kind of the difficulties that we have in helping patients to stay alive and well into the longer periods of time in later stage disease. We know that screening patients with low-dose CT scans when they have a history of smoking can reduce the number of deaths in lung cancer. That was shown some years ago in the US, and they have a recognized screening program in the US, and other countries are following suit. And we're in the early stages of a national program within the UK. And essentially what we've done is to take multiple different sites across the country in a very collaborative approach to see areas where there are high rates of lung cancer, to initiate a program of mobile CT scanning in those with high risk to try to find more cases of lung cancer early. To give you an idea of the scale of this program, we've now invited about 1.5 million patients to attend. They undergo a telephone triage to understand how much they smoked in the past, and those with the highest smoking histories and the highest risk are then invited for a low-dose CT scan. We've done about 300,000 baseline CT scans in these patients. And then the next slide will show us that the number of cancers diagnosed in these patients has now reached 4,000. Most of these are stage 1, so the earliest stage lung cancer, so 60%, and another 13% are stage 2. So 3/4 are at an early stage, which in comparison to the first graph I showed you, where there was about 20 to 30% at an early stage, really shows the importance of approaching the high risk and undertaking the CT scans. And this will be done every 2 years. We can see the speed of the program since the pandemic has really picked up from very low numbers here, and now we're diagnosing between 100 and 200 lung cancers per month in the program. Obviously, we don't just find lung cancer in these scans, we find many other lung conditions. And so we have to think carefully about how to manage the amount of work that we're creating, and that potentially augments the opportunity that AI may face. Similarly, we need very expert radiology doctors to read these scans because they can be very small early cancers. And so imagine the expertise that we need to locate to do this. And so this really sort of sets out the challenge that we need to consider when we are approached with opportunities to undertake AI. It's important also to recognize that all of these scans, that a comparatively small number have cancer. And so perhaps we might be able to improve what we're doing by sort of focusing in on these cohorts more. Some patients will need repeat scans, which can cause anxiety before it's confirmed. Some patients will need biopsies and potentially don't have a cancer, and so there's a risk there. So sort of thinking about these challenges, how might AI apply? All of this, of course, has happened in the context of a recent pandemic where respiratory and cancer patients have felt anxious about coming to the hospital, and respiratory and other doctors are feeling overwhelmed with the amount of work that has presented during that time. So trying to contextualize what AI means in a clinical pathway, essentially all we're doing at the outset is curating data. we're finding an area of the scan that we consider to be abnormal, so detection of a region of interest. And then we're trying to say, is something cancer or is it benign? So a sort of clinical decision-making process and thinking whether that applies, and then trying to ascertain what the best approaches to treatment and prognostication might be. So in terms of the data storage, we've taken one approach, our trust, working with something called XNAT or Incita, that's essentially a cloud-based computing environment that enabled us to work in a more collaborative way in some of our AI studies. And I think that's going to be important in the future to think that the expert teaching hospitals will be well placed to develop some of these approaches, but then working with the wider number of centres that are delivering clinical care to make sure that they're well placed to use some of the latest technologies, considering how that resource might be different between an expert centre and a more regional centre. I think it's also important to consider there's a wealth of different data types out there. So whilst we see a lot of the challenges around imaging, by building collaborations such as this grant consortium, where we can understand not just the CT scan data, but also things like biopsy pathology data, other clinical data, blood test data, to really build in a kind of a unified approach to doing research in this setting.
Can you please slow down a little bit?
Sorry, of course. Thank you.
Thank you.
So trying to think about, there would be a number of experts here in medicine, a number of experts in AI, but trying to kind of contextualize why this is important. So if you can imagine, we are doing thousands of CT scans, so thousands of scans that need reporting. Sometimes radiologists miss things on reading scans. You know, we are humans, so we have to think about how we can safety net that reporting process. So if you imagine this simple children's game of trying to find Wally, essentially finding a nodule or an abnormal area on a scan is a similar concept. So you can apply AI to detect these nodules. That's computer-aided detection. And the example Dr. Kazmi mentioned before, Aidence, is one of the common platforms in which to do that. And that is now mandated within the lung screening program so that cases are not missed. And that helps us to understand which lesions might need follow-up. We don't know much about how we compare different softwares, so that's going to be an important challenge, because what we find is that market forces will present one option that is very easy for everyone to choose, but obviously we need to think about whether there might be one option that's a better quality, or whether the prices are potentially different for such a large-scale endeavour. Similarly, we have existing clinical guidelines about deciding which of these nodules are more likely to be cancer and which are less likely. So we use these models to try to help us decide which patients we can reassure and say we'll do another scan in a few months, versus which patients we need to investigate more aggressively with biopsies. And so what we're starting to see is how can the artificial intelligence inform these decisions. This is something that the science is now approaching the degree of accuracy that we think might be ready for clinical intervention studies. But so one of the really interesting things that we see with so many of the AI studies, you can prove that the concept works, but actually trying to bring it into clinical implementation studies, i.e. studies that might change care for patients, is very much more challenging, and I think is going to be one of the important focuses of research in this area. So we know, for example, we and others have done work where you take a nodule like this, the little round area on the scan, you can kind of simplify what its shape is, and you can turn that into a numerical form. So things like shape, texture, density, and then you build essentially sort of advanced statistical models or sort of machine and deep AI learning models to try to replicate the decision-making around whether this is abnormal. And these kind of curves that we have to use to decide if these models are working are now getting better and better, to the point that they are starting to compare with some of the other traditional models we've been using. So what we end up with is a situation where we think, well, how do we start to look at what radiologists might be able to do with this information? So one of the interesting studies from Google said, well, if all of the colored dots here are how a radiologist might perform, this line is the AI. In some circumstances, the AI is almost good enough now to kind of match or outperform the radiologist in the setting. What's interesting is if you give a radiologist two scans, the one from now and one from a few months ago, the radiologist is good at telling if something's grown or if it's changed. That clinical decision-making is very strong when you have historical data. the AI tends to fare less well in that setting at the moment. And again, that's another area that people will need to think about in the research of this. So thinking about how you apply AI, you can say, well, let's do the AI first, and we'll find the most dangerous or the most difficult cases, and we'll triage using the AI. So things that are likely to be cancer, let's put those in front of the radiologist first, and then perhaps the more simple things, we can try and sort of take those at a slower pace because it's less urgent. That's a first reader. Or you can say, well, the second reader is better. You know, you rely on the clinician first, but sometimes they miss things. So let's use the AI as a safety net, just to make those additional checks afterwards. Or you could say, well, actually, the two things combined, so a concurrent reader system is the most valuable. And then you could try to ascertain if you can improve the radiologist performance by showing them the data. So these are the studies that we really need to start to do to understand where that is best placed. One of the studies in lung cancer that we're doing is called the DULCE study. Essentially, what we have is an AI product that's on the market. This one's called Optellum. And this particular product gives you a score. So it gives you a number to say if you're very high risk that a nodule is a cancer, it will give it a 10. And if it thinks that a nodule isn't a cancer, and you can reassure the patient, it'll give it a 1. And this study is looking to say when you give the radiologist that information, how does it change their decision making? And in comparison with that, we'll see then, did the AI get it right? So these are the kind of studies now in a kind of a prospective way we need to see. This doesn't change the patient care, and I think we really need to get to those studies, but this is like the kind of the next step on the way to that kind of work. So coming back to these sort of lung health checks, we might also have opportunities to think about, well, we're sending out invitations to very many patients and we're doing these risk scores. Can we improve how we're selecting people? So I said that for every 100 patients we scan, maybe we find 1 or 2 cancers. That's a lot of scans to do. It's a lot of cost to the health service. It's a lot of radiologists. Perhaps the AI can pick out the right patients to scan in the first place. Potentially, it can help the radiologist reporting. We've just been talking about that. Potentially, it can choose who should get the biopsy, who should go straight for surgery. And these are the kind of areas that potentially that can be thought about in this diagnostic pathway. I think it's important to recognize that trying to find the applications for AI, one of the things we've thought about is, okay, what are the biggest kind of clinical initiatives? So we make sure that if we find something that works, we get a sort of a big opportunity. And lung cancer screening is really evolving rapidly in the US, UK, and internationally. That also presents challenges. You know, there's large quantities of data, and thinking about how we'll bring these different commercial parties in and how we will be able to choose between the different versions. Obviously, the clinical decision making isn't just about is this cancer or not cancer. Some things might be cancer, but may not be harmful to the patient for a number of years. Some of the very smallest lung cancers can stay very small and harmless for 5 to 10 years. And so then thinking about prognostication will also be an opportunity. There's other opportunities thinking about recurrence. So some scans that are done after radiotherapy, including the planning scan for radiotherapy, can potentially inform how the surveillance of the patient follows. So if you're thinking about patient choice for particular kinds of radiotherapy or adjuvant chemotherapy, in this study, we took the scans that the radiation oncology doctors make to plan where the radiotherapy is given. And we said, well, that is the region of interest that we can use for AI, and tried to understand, could we predict the patients that in whom the cancer might come back? Could we understand those that were more likely to die because their cancer treatment had failed? You know, there's a big worry for patients after their cancer about whether their cancer will return. So I think this is another interesting area in which we'll understand, can we make an earlier diagnosis of the cancer coming back? The other thing that we see a lot of is even simpler than that. So it's comparatively easy if we have a small lung cancer or a small nodule on the scan. But if you think about the simpler modality of chest x-rays and just how many are being done, even in the UK, we struggle with the number of chest x-rays that happen. So there are something like 8 million chest x-rays done by primary care for cancer in a year. And it can take quite a lot of time for the radiologist to report those chest x-rays back. And so actually trying to see if the AI can stratify that could be very valuable. And so in this case, the Cure software is one example where it can pick up abnormalities And there's a study called Lung Impact, where the chest X-ray is reported by the AI as being abnormal or not. If it's abnormal, a radiographer will then flag this to the radiologist and say, this X-ray Liz's looking at today, let's get this patient back for the CT scan today if appropriate. And you can take several weeks off a diagnostic pathway just by making somebody look at the chest X-ray in a timely manner. And so the software is quite clever. The application is something very straightforward. And I think this is the big challenge now, that people present with these clever pieces of software. How do clinicians on the ground think, I just need something to do this simple task, and then sort of planning a study around that. Other sort of cleverer things that we might try to do in the future is, we don't want to give everyone contrast. Can we use deep fake style AI to add details of contrast onto a scan? And that's something that's being considered. Similarly, there's a lot of information in the radiology reports of the wording that the radiologist uses to describe a cancer. And we did some work with natural language processing AI to look for the scans that might have lung nodules because of the wording of the report, and therefore that could be useful for us for research. But potentially that could be a red flag system to say, we found a nodule, bring along the chest doctor to give us some extra advice in this setting. I won't talk so much about things like bias and data security, but obviously there's a lot of interest in safe use of AI at the moment and understandable AI. And I think as we sort of embrace this journey, we need to really think carefully about what we're bringing into the hospital systems, and sort of think about how have we thought about the right populations. You can't assume that the model has been trained in one setting will apply to all different demographic groups. Similarly, we have to think about what if the population changes over time because of different lung cancer patterns, different smoking patterns. Is the AI still valid? There's a few questions here for the future. Is AI better than radiologists? Is it just about thinking how to work with the radiologists? Are some lung cancers easier or harder to diagnose? Radiologists will find some cancers easier, some cancers harder, and I'm sure that AI is going to say the same. Similarly, in some centers, you have the very best radiologists in the country, but that's only in some centers. We need to make this sort of equal across the country, and potentially AI can help with that. I won't go into detail here. I'm happy for people to see my slides, but just to sort of highlight, in breast cancer early detection, very similar concepts. They are further ahead than we are in lung cancer, actually sort of testing these concepts of first and second reader of AI. Similarly, in the field of using whole body MRI to look at bones rather than just bone X-rays can help to improve the sensitivity. That's a very complicated skill for the radiologist. It's a very sort of data intense thing, but potentially AI might help to find these very small lesions that otherwise wouldn't be picked up by X-ray. So I think I'm more or less at the end. Some acknowledgement slides again, I'm happy to share. And just again, thank you for the invitation. I've had many happy journeys and work experience placements in South America. So again, muchas gracias por la invitación y espero que estoy con ustedes en el futuro. Thank you very much.
Thank you very much, Dr. Lee, for your excellent presentation that highlights the need of working harmonically between the different areas that are relevant for cancer care. And then also we add the use of technologies through protocols, procedures, software to really have an early diagnosis. You also mentioned how all of these advances have taken place in the diagnosis and identification of lung cancer, and you now have percentages that are really, really important. 72% of the patients in being detected with maybe a stage 1 and 13% in stage 2. Also, you have given us a really, really important example, and we have seen this during the pandemic also, and that is that information is being now uploaded to the cloud, and that we have access now not only to the data of research, but also to the results and outcomes and this shortens the times to get to the diagnosis earlier. Also, you highlighted the need of having more accurate radiological results and CT scans, because the number of experts in radiology that are really good, they're very few as compared to the demand. And so AI maybe has allowed to identify more rapidly and better, and to providing the possibility of screening this diagnosis early, and then to provide this information to the radiologist, and it allows to really have a better response. Thank you very much, dear Dr. Lee, and also allow me to tell you and to ask you if you could stay here, because we're going to move on to the second section, which is the Q&A. So, well, now first I would like to thank the presence of the different officers from the Ministries of Health, the academia, the different SCOs and public entities and private entities, and also the general public. Thank you for being here. We have information that we have people from Argentina, from Belize, Bolivia, Chile, Colombia, Cuba, Ecuador, Spain, United States, Guatemala, Mexico, Nicaragua, Paraguay, Panama, Peru, United Kingdom, Uruguay, and Venezuela. These are the attendees that are present now, listening from all of these countries. We would like to thank also the presence of the US, the British Embassy, and also the authorities that have been joining us in these exchange of ideas and knowledge. With us, we have to participate in the dialogue, we have with us Dr. Daisy Milagros Maradiegue. She's the executive director of the Directorate of Cancer Control and Prevention from MINSA, from the Ministry of Health. Also, Dr. Francisco Berrospi Espinosa, head of the National Institute of Neoplastic Diseases or Cancer Diseases, INEN. We also have the past president of the National Institute of Cancer. We also have Dr. Reina Bustamante, advisor on public health of the Vice Ministry at the Ministry of Health. There are different representatives, doctor from the National Children's Hospital, and then also Dr. Diego Venegas, former Minister of Health, and also an expert on oncology. So we're going to give the floor in order to kick off this Q&A. Dr. Essie Milagros Maradiegue. Please, Dr. Maradiegue, you have the floor. Good morning, and thank you very much. Thank you for the excellent presentations. Well, definitely, I wanted to start by just contextualizing Peru's situation. Peru is a middle-income country. We have approximately 70,000 new cases of cancer per year, and we really have challenges, important and significant challenges in the context, that cancer, as a very complex disease, cannot be handled or treated different from what happens in the more developed countries, and it shouldn't. So for us, as a country, I would say, even though that we are classified as a middle high-income country, really, that is just based on economic numbers. But culturally, educationally, and socially, economically, we are not. We are we are a developing country, a true developing country. So how can we actually integrate technology for cancer in our situation as a country? And this is the first thing that I ask. And so really, the progress is made by United Kingdom, really is amazing, where the staging of cancers are being diagnosed, the cancers are diagnosed in an early stage, better yet, and almost 75% of the cases. That's amazing. But in Peru, it turns out that almost 7 out of 10 patients are diagnosed very late. So how can we integrate technology, or how can we really take advantage of training that can be done with technology? I think this is also an important, and also provide sustainability that is required, because that is another key point. So these are many questions that come to my head, but I think it was really interesting, the first presentation by Dr. Kasmi. And I want to stay with the last part of his presentation, where he talks about a way of training. I think that the first, the key part has to be education. We need to start, with education. I think for us and for many health professionals and many professionals in Peru, AI is not really part of our thinking, our collective thinking yet. But I think it would be very interesting to change that and to have some sort of a link to start doing that, to be able to start relating to it in a better way and to actually broaden our view about that and especially and start with education and training. I think that is the way we can start thinking about that and improving from the technological standpoint, detection as well as diagnosis of cancer. So, well, I don't know, Dr. Majid Kazmi, this is, a question to you. How can we actually start doing that? How can we start incorporating AI and technologies into training? Dr. Kazmi, you are acknowledged.
Thank you. The really important points raised by the last questioner. So I think talking about education, I think that is vital. It is a system-wide education, and as much a public education exercise as it is a medical and clinical education exercise. So one of the things we're focusing on, and so what we initially started off was with a education program for doctors and nurses, and what we quickly realized is that we need to develop education programs for patients, because the more patients understand their disease, the more they can ask the right questions, the more they can seek the right kind of treatment options that are available for them. And where we're going in the future, I think, is that we are going to use technology. We'll never get rid of the doctors and nurses because those are really important. But what we want to have technology doing is raising the standards in a much more equitable way. I think, as Dr. Lee said, where there's too much variation, and at the moment, a patient outcome can be just simply determined by which hospital, which doctor, which nurse, was looking after them. And I think that has to change. And then particularly in countries where the resources are restrained, then I think wise implementation and deployment of technology versus the investment required, for example, to train an oncologist from the time they start a medical school, their postgraduate training, and then become an oncologist, and then to keep them in their field. That's a huge investment. If you were to take that investment and then compare that with technology, you may find the economics actually are very, very different. So I think it's about the smart deployment. And going back to that ecosystem that I talked about right at the very beginning, cancer is a global challenge, and we're all in it together. None of us have solved the issue. We're all working at it at different levels, different challenges, but it's a global challenge. And what I would see is countries like Britain, where we have made some advances in certain areas, we need to support the developing countries with that technology. So the example I gave about the radiotherapy, we are making that technology available in Africa. So where they can't, they will not be able to have the medical physics to do the planning. We are taking old LINACs that have been decommissioned in the UK. We'll put those in those countries, and then we will help them support the delivery of radiotherapy in those countries. So there are things that we can do. You can do in-house and in-country, but there are also things that we as a global community can work together to come and support things and collaborate on these initiatives. And actually, it's a bi-directional collaboration, because AI and all these technologies are all great, but at the moment, if you look at them, they're all being developed on a very small percentage of the population, usually white, middle class, Caucasian. That is not the world. And we need to collect this data from around the world to really understand whether these AI technologies we're using really work in different parts of the world. We don't know that. And so for me, it's a bi-directional collaboration. We will help you, but you will help us by giving us the data that we can work together and understand really, is the tools we're developing really valid in all parts of the world? We do not know that right now.
Muchas gracias, doctor Casmi. Doctor,
Thank you very much, Dr. Kasmi. I don't know whether Dr. Lee would have some comments to make in this regard.
Yeah, thanks. And it's great to hear your views, Dr. Kazmi. I think trying to think beyond that, the important point you make is trying to make this sort of opportunity there for across different sort of sectors of the health system. You know, we know in the UK, we've seen different parts of the country with deprivation than other parts that are much wealthier. And so our lung screening initiatives have focused in areas with high lung cancer that actually turned out to be the areas with most cigarette smoking, and actually then have correlated with deprivation. And I guess a similar idea would apply internationally, where, you know, potentially I'm very familiar with the Peruvian health system when I was working there, and I sort of recognize there are areas of high quality care across the board, but other areas where the resources are more stretched. And so trying to stratify where can you apply AI technologies if they're more expensive than basic treatment of patients with symptoms, and similar for screening, you know, is very challenging. Similarly, when we've started lung cancer screening in the UK, we've had to prove that it's cost effective. So we know that it reduces the cost of care downstream, but it's trying to find that balance of how you spend the resources that you have in an appropriate way. And so I'm sure people will find ways that AI can improve cost effectiveness, but I think we have to be careful to follow those principles, not just say we can screen for this disease or we can use this an AI approach, but in which ways will it improve the care or to make it more cost effective? You know, in every healthcare system in the world, I think we're always conscious of how much it costs to provide that care and to do so equitably. And so I hope with AI, you know, a similar concept will be applied. You know, is it cost effective?
muy gentil, doctor Lee.
Very kind, Dr. Lee. Now we would like to invite Dr. Francisco Berrospi so that he can make some remarks. Good afternoon. Thank you very much for your presentations, Dr. Kasmi and Dr. Lee. Quite interesting, your proposals. Well, we are in a country, as my colleague said, well, she already mentioned some details about the conditions of our health system, and it is completely different to the ideal world that you're talking about, a world that we would like to be part of. But in fact, I work at an institute of cancer that offers highly specialized treatment, and artificial intelligence can help us in many, many things, perhaps not only at the level of our institute, but broadly speaking, in order to revert the figures that you have shown us about early cancer, 70%, versus what happens in our country, advanced cancer, 70% or more. So some things about it, artificial intelligence, I believe that technology always changes the existing paradigms. And I heard Dr. Kasmi say that if we empower the patient with this technology, we might even be able to facilitate and make his life easier, not only by providing them treatment, but also solving their advice, and perhaps even avoid a multidiscipline, the MDT, which is the multidisciplinary team. I don't know how much this could be changed with these new technologies, that these, of course, we can never do without doctors, but perhaps they can just make the process faster. So, and this is how we're going to improve and help the patient, and also make some processes faster particularly when we talk about early diagnosis. So my question is about the change of paradigms that I just mentioned. Thank you. Thank you, Dr. Berrospi. Dr. Kasmi or Dr. Lee?
Y doctor Lee posteriormente.
First,
So
Dr.
again,
Kasmi.
yes, thank you. It's again very good points. I think Yeah, as clinicians, certainly my experience is that as clinicians, we are seeing out of 100 patients, you'll see a certain percentage which will be straightforward, which you know what to do, and it still has to go through an MDT process to get sign off, etc. But for me, what we're really doing is some form of triage, which is what kind of patients really could just go through an automated process that doesn't need that human interaction. They still will need the clinician at the end to sit down with a patient and say, this is the outcome that has been decided, and these are the reasons why, and this is what we're going to do. But there are still going to be patients that don't fit the boxes, and we found that even through our validation, that they're not fitting all the right boxes. They need that human discussion, but you're then freeing up time to do that. So that's where it kind of changes your pathways and allows you to do things slightly differently. I think going wider than that, one of the exciting things I didn't talk about, again, you could say this is a bit of a luxury you may have in the UK, but it's going to be increasingly important in the rest of the world, is we're now building in patient expectations into the MDT decision. So you can load, for example, if you're a male and you're going to have you've got prostate cancer and you're going to have treatment, what is most important to you as a patient? Is it incontinence preservation? Is it sexual preservation? Or is it just curing the disease at all costs? You don't really worry about those other things. Everybody's different, and patients will have their own views of what's really important to them. And so they can start putting that into the algorithm. We can then start to nuance the decision making to sort of come out with the list of recommendations I talked about, but ranked differently depending on what patients are also telling us. So this is the future that's coming. It's really exciting, and it's involving patients much, much more in their decision making. And then they will take shared responsibility of the outcomes and everything else that goes with it, with all following the treatment plan, etc., etc. I recognize, and my family background is from Pakistan. It's an equally difficult country where the resources are really, really tight. So, and I've been to Libya and other places where resources are very, very stretched. So I understand that, somebody coming in saying we should be doing AI for everything is not, it's not realistic. There are basic things that also need to be in place. So I'm not saying we've got to, AI will solve everything. What I'm saying is technology can potentially help in certain areas. And if you do, as Dr. Lee says, if you do that cost-effective analysis properly and you build that into your pilot design when you're evaluating the technology, and it has to be localized to the health system within which it's being deployed. So there's no point in me doing a cost-effective analysis in the NHS and then coming to you and saying it works, because it may not work in the Peruvian health system. So it's got to be localized to what's going on in the local economy. But if you design your initial pilot studies properly and answer all of those questions, and then you'll have an answer which will either make the decision for you that yes, we should deploy this technology, or no, it doesn't really work for us in our economy and in our system.
Yeah, I would agree with that. I think one of the things I was trying to do in my presentation was to select examples that showed a breadth of application. So yes, there's a lot of focus on lung cancer screening with CT scans, and if there's a way to make that work, it's very effective. But I guess you need a cancer plan that's relevant for your population. And if that cancer plan says we need to be able to deal with chest X-rays quickly in people with a cough or coughing up blood, then the AI can support that application. So I guess it's about being strategic to the problems that you face and that are most important, and then looking for AI technologies to support, implementation of good care in those areas. And if it's advanced cancer, that could be about symptomatic cases. There could be something about, data and registries and making sure that you understand your cancer population. It might be something about helping to implement smoking cessation and sort of prevention approaches. And potentially CT could be relevant in select groups, but it's about picking the AI applications that can support the things that you feel to be important clinically.
Muchas gracias, doctores.
Totally agree. Thank you very much, Dr. Kazmi and Dr. Lee. I would also like to greet participants who have joined us through Zoom from Angola, and also the team from the Pan American Health Organization and the group working with cancer, and also to the team from the Ministry of Health of the Cancer Department from Mexico. Now we would like to invite the Dr. Eduardo Payet Mesa for his remarks. Good afternoon to all of you. Well, I would first like to thank Dr. Mariel Carmen for her invitation, and of course, to all of you. Warm greetings to you all. Instead of talking about the future, I'm going to try to explain in very short words what has been done. And I believe that in Peru, we have made some progress. We have been able to advance in the management of cancer. Today, cancer is in the public agenda. We are all talking about cancer. There's a national law on cancer. In other words, in the recent years, it has taken some time, but we have made it so that it is now present in the agenda of the politicians, of the academia, of industry, and all together we will be able to just move forward. It is true, we live in a country where we have advanced cancer and we dream about a free cancer world. And we know our figures, we know that we have a dual pattern of disease, some cases that can be preventive if we identify the risk factors. For example, the papillomavirus, Helicobacter pyloris, hepatitis B virus, all the... And these are the most important causes of mortality. But all this is possible if we learn about the X-ray of cancer in our country, and high quality data. Well, does not reach more than 10%. In Peru, we have a couple of register for cancer that take and analyze 38% of the total population. And these figures can be extrapolated by international organizations and allows us to establish health policies. We also know that in our country, there is a transition, demographic transitions and epidemiological. Cancer is the second cause of death. The decrease of mortality for infectious agents has occurred in our country. There's an increase of life expectancy, and you know, there's effect of the chronic aspect of the disease. And this, well, at one point we said that the elderly people are living far too long and that this is generating a health burden for our health services. And 90% of the Peruvian population is covered by some sort of public health coverage. However, the health centers in our country at levels 2 or 3 only reaches 3%. In other words, our population is insured into a way. We have a comprehensive health insurance that has a bigger coverage in cancer that even that private insurances. However, when we talk about opportunity and sustainability are still topics that need to be further discussed. So we need to systematize our systems. We need to study opportunities, and what we have to do is mobilize society. And what are the tools that we can use to mobilize society towards this timely diagnosis and towards a preventive diagnosis, a healthy lifestyle? These are topics that have been touched here, applying education methods, amongst others. So this could just add to what Maria Carmen said earlier. What did you remember say? You said that the budget goes hand in hand with all these studies. I would have to add that if there is no political willingness from people who are in charge at this point, then we will not be able to move towards artificial intelligence, towards a robot and all these things that we want whenever we think about improving the primary levels of attention. I've lived in the UK. I'm a fellow from the Royal College of Surgeons, and I've been a student in the UK, and I know about their systems, and I'm a huge admirer of the NEST model. However, we think that Peru has made some progress in several areas. As I repeat, we have a national law on cancer, which is still under discussion about its implementation, but it'll come one day, and there's a lot of willingness to move forward. And this is the comment that we wanted to make. I don't know whether our panel of experts would like to answer. Then Dr. Kasmi or Dr. Lee, you are acknowledged if you so wish.
I mean, only to say that no country has solved the cancer challenge. If anybody thinks even the US or anybody else has solved the cancer challenge, no one has solved the cancer challenge. And I think it's absolutely right what's been said, that you have to have a plan that you think will work for your population, and only you as the experts in your own countries will really understand what you think will work for your population. Now we can come and we can give suggestions and we can talk about things we've done. Some of them will work, some of them won't work, but a coherent strategy, a plan, I think as Dr. Lee said, and as has already just been mentioned by the previous speaker, you know, it requires a coalition of the willing. It requires all, you know, I talked about the multi-agency approach at the beginning. This no cancer doctor is going to solve this issue on their own. Education, even from the childhood education around good lifestyle choices, behaviors that start off in very young age. You know, all of these things will make a significant impact. But there is a transition, as has been said. You know, you've got patients today who are presenting at your front door with a cancer diagnosis, and prevention is too late for them. You've got to have a plan for what you're going to do with those patients and how you're going to give them the best experience and the best outcomes. But then with a longer term, any cancer plan that doesn't have a longer term view on prevention is really going to struggle, because none of us can afford, you know, if you think about the economics of treating someone with advanced cancer and how much some of these new therapies are costing, no health economy, you know, the US is over 2 trillion now, isn't it, on health? No health economy is going to be able to afford it. So you have to have a long-term plan, and with a willingness to buy into it for the long term. No one's going to solve this, you know, in the next year or two. It's a multi, agency, but also a longitudinal approach, starting off with what are you doing about the people here and now in front of you? How do you improve those outcomes? And then what are you going to do in the longer term to reduce incidence and prevalence of cancer? And also remember, we, like many other parts of the world, we're seeing patients surviving with the first cancer to come back with the second cancer and the third cancer and all of these things. So cancer is not a one-off thing for a lot of people. They get one and then they get another. So, and a lot of that is things we don't fully understand about the immune system and all of those things which come with healthy eating, the microbiome, and all of these exciting areas of research. But right now, you've got a what sounds to me from what you've said, a real clear and present issue with increasing number of cases, significant numbers of patients dying every year with cancer diagnosis, your number 2 killer. And you've got to have a plan for those right now, what we can do to help you with that. And then in the longer term, it will be around a prevention strategy and a healthy lifestyle strategy.
Yeah, I completely agree.
Gracias, Dr. Lee. Adelante.
Yeah, I
Thank
completely
you, Dr. Lee.
And I think it's so important that you've got so many, expert senior policymakers in a room together, so you can, help to advocate for this. And, I think that's really important to have people who are really behind this cause on a kind of a national and international level. I think that's so valuable for the patients of your country. And I guess the only other thing that we find more and more in the UK is that we're really encouraged to have the patients in the room with us, in a kind of really inclusive way. So, thinking carefully about the diversity of the people we include, but to have the patients and the public in the room, and they use this phrase, nothing about me without me. And so, sort of if the patient is there and can advocate for the things that matter to them, potentially it just helps to, strengthen that. And those people are going to be very strong advocates. They'll approach their politicians and they'll complain in public. And so if you're trying to make a cause and you've got that very visible public argument, that should in theory be very supportive.
Muchísimas gracias.
Thank
doctor.
you. Thank you very much to both doctors for your comments. And we wanted in this second round to invite Doctora Reina Bustamante, his advisor to the Vice Ministry of Health in Peru, so she can share her technical vision. She's an oncologist and she's going to share her views with us. Well, good morning to you all, to all the members of the head table, and for the speakers. Well, thank you very much. We know that the British system is one of the best in the world, so I'm an absolutely fan of your system. So in that sense, well, there are a couple of questions, but perhaps, well, you have shown us the use of technology, and for us, well, we should try to address the best use of it. We all know that the big gaps that we have in our country, because in Lima probably concentrates 1/3 of population, and even in Lima itself, we have big gaps in terms of prevention as well as in topics related to cancer treatment. So we can imagine how it is in faraway areas, in the Amazonian area where we have native communities. They have very little access to all these health services. And this is why I think when I was talking, this innovation, technological innovation could be a lot of help, because we have a lot of constraints in terms of the human resources. If we want to do just CT screening, perhaps we can place the equipment, but we do not have radiologists to operate this, or with all these algorithms that could help us predict a suspicion, lesion, an injury. This could help us for another doctor who is not necessarily a radiologist, may just look into this case and then just refer it to a more specialized care, so as to give an early attention to the patient. So this is basically, I think that this is a huge challenge for our country, and the fact that we have the authorities who have been from the Ministry of Health, like Dr. Venegas, who is a connoisseur, and Dr. Berrospe, Dr. Milagros, who, she's leading all these strategies aiming at improving the current situation. Also want to acknowledge Eduardo Payet, who was an authority, and he's really very recognized because of his experience, and we know all the work that he has done to just help solve this huge challenge that is cancer. So next week, you will have the information of the Impacta group, and they will give us some idea on how we are responding as a system to this huge challenge, which is cancer management. I believe that we have improved in terms of screening, because this is a huge challenge for our country, because as Dr. Maria del Carmen said, without the budget, it's very difficult to guarantee some sort of intervention. And we at the ministry, well, we have to fight or struggle with the Ministry of Economy and Finance so they can offer us the funding that we need. Well, of course, we won't get everything we need, but in the past 3 years at least, there have been some additional requests that have been taken into account, and we trust that we will continue with this vision of trying to change the face of cancer with the support of certain technologies as have been presented by our British speakers. They just give us their perspective. They just work in health, they are clinicians, and the information they share with us is of the essence. And I really like the fact that you mentioned having the patient in the center of everything, because it is the patient himself, the one demanding the care, and also provide tools to civil society and provide them with these technologies. Sometimes, perhaps, we might be asked about what prevention measures can we implement, and thanks to all this technology, we will be able to provide them with broader information about this. And the big challenges for our ministry are very, very big. And well, in view of all the political turmoil, well, in this country, we have tried to attract the attention of authorities, because in the end, we want to work in favor of the patient. Our vice minister was not able to come here today, but he asked me to express his warm greetings and thank our British speakers for having shared with us such important information. And thank you for showing us how to use intelligently all these tools that we hope would be at our disposal some days. And once again, my thanks to Dr. Kasi and Dr. Lee. And the question, how did you manage the change in Great Britain? Perhaps you can share with us some of your experience, because we know in our case, when there is innovation, the big challenge is how to manage change. So perhaps you can shed some light about this. Dr. Kasmi and Dr. Lee, you're acknowledged.
Very good questions. I've been practicing oncology now for about 30 years, and even in the UK, 30 years ago, patients used to come into the hospital through the back door because they didn't, it was felt to be too uncomfortable for other patients to see patients with cancer. And it's only 30 years ago in the UK that was happening. So what's really changed is, as a society, we have taken on cancer as a challenge for us, and this profile has been raised significantly across the whole of the population. So there's huge awareness around cancer, there's huge public interest, huge public engagement, and I think, as Dr. Lee said, that is a really powerful advocacy, because in a democratic society, you can vote out your politician and you can say they're not delivering what you want them to deliver. And the health systems had to respond to the demands from public and clinical teams around cancer. Now, we have to be honest, if you speak about mental health, that's only recently really raised its profile in the UK. Mental health has been considered very low priority until recently. So these things, just happen with time and with the right people and the right kind of influencing at the right level. And sometimes it's as simple as even an individual in a senior position being affected by something, or having a family member being affected by something, that can really transform thinking. What you do with that afterwards is the key. So if you get that opportunity and the profile that door gets opened, it's how you then leverage that as much as possible to get the maximum kind of sort of investment and sort of engagement. And that is difficult because pressures on every economy, you know, the NHS, we can look back, and I've been in it for such a long time. We had a cancer plan, we had three cancer plans. Recently, the government decided not to have a separate cancer plan because it felt it didn't need one. Well, actually, it still needs a cancer plan. And so I think these things can ebb and flow. I think in all different countries, the only people who will really be able to come together, the people who are on this call in the room, the people who really understand cancer, working with their communities, working with their patients, working with influencers and advocates and politicians and the systems to try and make a difference. But it's never a quick change. It's taken 30 years to now cancer, even in my own organization, Kaiser and St. Thomas's. I'll give you an example. When I was first appointed as clinical director, cancer was number 17 on the priorities of the organization in which I was in. It was so low down on the priorities. And I had to fight to become number one priority for the organization. I had to, and the reason why it became number one was a simple economic reality for the hospital. It did not realize that 25% of all its activity was cancer related. It had no idea because we weren't coding the data. And I think the point I was made earlier about the data, that's really important, because once you know how many patients are being affected, how many people are coming through your door with cancer, then you suddenly realize you've got to deal with it. You can't ignore it. And so all of these things come together, making sure you've got good data, collecting the data that's relevant to you, having the right conversations with the right people, and having a long-term plan for what you're going to do. None of these things will happen on their own.
Yeah, I think super important points. I sort of just reflecting on sort of things I've seen since I've come into this role. I think we've had some very important documents published. So the long-term plan for the NHS, the 10-year plan, I think was excellent for cancer. It had a very prominent role for cancer in a kind of a document that really steered national healthcare. I think we've got a very strong cancer program team in the sort of the central national part of the NHS, and a very sort of strong national leader, or leaders that do that. And then I think similarly, there are so many people within the NHS and third parties and charities that I think have really pushed through. So things like the kind of the great sort of aspiration to diagnose cancer early. I think people have really pushed for that because they really believed in that. So I think there's something about that strong 10-year strategic document I think people have really gotten behind. So, you know, I agree with your points and those of the committee. I may have to excuse myself soon, I'm afraid, due to other commitments, and I'm sorry to have to leave earlier. But I've really found this discussion very, very valuable, and thank you for the invitation.
Muchísimas gracias por sus ponencias y bueno,
Yes, thank you very much. Thank you very much. And of course, I know you need to go because you have a previous commitment. So we're going to invite Dr. Maria del Carmen Davila for her to give the final words. Well, first of all, the first few words are just gratitude, because really the amount of information that you have shared with us has been so valuable. It's been excellent and really, really priceless. It's been a tsunami of information regarding artificial intelligence. We cannot really be reluctant to change. Definitely AI is important and is here to stay, and we need to know how to use it. And it is important in the two main areas, and you were both very clear, not only in terms of early detection, but also in treatment of advanced cancers, because in both stages, you know, AI can really provide possibilities for the patients, better possibilities, so for our patients. Today, we have heard many, many important things. One of the most important things that were mentioned is that the patient has to be at the center of all and every single care activity. We have recognized that there is an ecosystem, and the ecosystem around a cancer patient is increasingly big and more complex. we've also heard that there are atypical presentations of cancer where maybe, it's a third of them, and we will need to use methods and approaches that are different and maybe more modern to be able to really get to an accurate and precision diagnosis. But also, we have heard about the importance of the active engagement and participation of the patients. I really liked that idea that, nothing about me without me. And I think that is key, especially about something that involves such a long-term disease, because with with all of the progresses and breakthroughs, we know that cancer also can take long. It's not that somebody will die overnight unless they come in the late stages and it's terminal, but otherwise it's going to be a long-term disease. And we talked about prevention, and we talked about healthy lifestyle studies, but then we also heard about vaccines, HPV, we heard about hepatitis, and we heard about Helicobacter pylori. So, well, it's not a vaccine, but it's preventable. That's what I mean. So I think we need to keep on learning. And to keep on learning, we need to do research. We need to study. And I think that one of the things that we have heard repeatedly from both speakers and from the commenters is we need to really study and research and to generate intelligence, because definitely AI can help us in many areas, but we also need to have evidence. We need to do evidence-based medicine, evidence that using AI, we're actually improving diagnosis, we're actually improving costs and reducing costs, and we're improving efficiency and the effectiveness of our treatments. We need the evidence of that. And I've borne witness that definitely we have gotten better in Peru, but it's been years and years of work. And, it's been a slight progress, but it's progress anyway. I have also borne witness that the ORASCONU, the Andean Health Organization, since I took over the leadership role, we have given much importance to cancer. And I think this is something that before that, really, nobody talked about much. And we said, you know what? No, cancer is not going to be just part of non-communicable diseases. Cancer needs a separate plan. Cancer has to be dealt with by its own. And this is also something that comes when we talk about political willingness and political will. And it not only at Peru, but also the 6 countries, the ministries of health at 6 countries, they have cancer as a separate plan. We haven't talked about pediatric cancer at no point, but we know that this is a whole different beast. And why? Because this, we're having higher remission rates, but we're also having a longer life expectancy. And the problem is, okay, we need to think about quality of life. And, this is something that more developed countries has already, with patients that go through childhood and adolescence and adulthood with cancer. And that is, that's a whole different topic for another webinar, not for this one. But let's not forget that artificial intelligence implies many things. So when we talk about AI, we are talking about early detection. We're talking about reaching, smaller nodules or tumors. We're really talking about other things that can, targeted interventions. We're talking about targeted radiotherapies, immunotherapies. We're talking about many things that can really be supported by AI. And in the end, I think this is the reason why we are having this very special webinars we're doing with the British Embassy. Definitely, you have been very clear. We need to exchange information. We need to exchange knowledge. We can give you data, and you can give us, training, capacity building, and possibilities of a better, an improvement. And webinars for us our continuous learning processes. You know, it's not just us learning, but I think you can learn something from us too. So thank you very much. Thanks again for your time, for the willingness to share your knowledge. And the next webinar, webinar with the British Embassy will be done in July. And we are talking about health primary care. Thank you very much to everybody who attended today. Thank you to the speakers. Thank you to everybody who are logged in, and in a special way, the whole team at the British Embassy, and also the whole team at Horas Konu for their support. Thank you very much, and good afternoon, good evening.